Hi, so today we're going to be talking about Josie. This is our case study for cognitive. Um, so we're going to talk about the agenda next. So the agenda, it's going to be case history, which I'll be doing, and then presenting problem, Alyssa. Assessment, Lily's going to be doing that. Treatment, intervention, goals, and assessment, Anala and Abria. The outcome, Hillary is going to be doing that. And then reflection, Chrisanthi. So Josie is an 8-year-old girl who was diagnosed with borderline intellectual functioning at the age of 6. At age 7, she sustained a traumatic brain injury after being struck by a vehicle as a pedestrian. Following the accident, Josie was comatose for 27 days and underwent 3 months of inpatient rehabilitation. After discharge, she continued with outpatient speech and occupational therapy for an additional 3 months. Josie is described as easily distracted and impulsive, characteristics commonly associated with both her TBI and cognitive challenges. Her mother also has a history of learning difficulties in reading and writing. Academically, Josie is reported to be performing below the level of her first grade peers, highlighting the significant impact her injury and developmental history she has had on her learning and communication skills. So next we're going to go to the presenting problem.
So, like we had already said, Josie is presenting with a TBI. So there are a myriad of red flags that I like to call them that are should be cause for clinical concern. So it is reported that she has severe destructive behaviors. So in the forms of yelling, aggression, throwing objects, and also self-injury. So these are obviously things that happened post TBI, so they are atypical and should be considered. At the school, she is showing elopement, which is a major safety concern. So we're really seeing just a lack of inhibition or just something going on with possible frontal lobe, cognitive functioning, things like that. With severe memory impairments, she has trouble remembering basic routines or basic expectations that are expected of her. So if she can't remember like a routine to get up in the morning, she's about 7 years old, and she should be able to remember how to wake up and get dressed and eat breakfast and do the things before school. She often goes off topic with difficulty understanding verbal directions. Aside with the like destructive behaviors, something that's also a concern is she has a lot of frustration and just overall emotional dysregulation. She has hyperorality, so in constant food seeking. So the hyperorality, she may be like biting things that are non-food objects, with the inability to participate in academic and daily routines. So this TBI is impacting her across the span. Um, and according to the CDC, these are cause for clinical concerns because these put her at increased risk for an repeated TBI, with decreased academic performance, as we know that she has an inability to participate in a lot of these things. She is at risk for social and emotional issues long term, if these are not addressed forthcomingly. She could have long-term behavioral problems if these aren't corrected, with communicative and cognitive challenges, and overall reduced independence and possible need for life support. So it's really important that she seek clinical direction, and therapy while she's in a period of life where her brain is more neuroplastic. And now we have what assessments should be presented for her.
Okay. So the purpose of these assessments is to determine what type of supports Josie needs to succeed, Determine why Josie's behaviors varied from classroom to her individual treatment sessions. Classroom observations. Josie's classroom was loud, unstructured, and distracting. Josie was expected to follow and remember routines. Josie struggled to produce correct answers, and the intensity of classrooms placed high stress on Josie's cognitive and behaviorally. The therapy observations, it was a quiet and structured environment. Josie benefited from clear, repeated instructions and no distractions from other students. Josie's sessions were 20 minutes, 2 times a week, and focused on positive interactions. Josie thrived in this setting and was calmer and more focused, and she was more successful. Interpretation. Josie's behaviors, her yelling, eloping, arguing, and defiance were not based in defiance, yet communication breakdowns. Josie benefited from clear communication, a visual schedule, consistent routines, minimal distractions, and positive reinforcement. Overall, Josie benefits most from a structured, supportive environment.
For Josie's intervention, we used a Vygotskian framework, which emphasizes supporting the child within their natural environment and using meaningful, structured daily activities to promote cognitive and behavioral regulation. The main goal was to understand what demands Josie faced during her school day and what types of support she needed to be successful. To do that, we gathered observations and reports from both her speech language sessions and her classroom to see how her behavior and communication differed across settings. And the assessment process included several key components. First, an environmental analysis, which helped identify when and where Josie experienced the most frustration. So during her unstructured free time or in noisy environments, that's when she was most frustrated. Next, a functional behavioral assessment was used to look at the triggers for her outbursts, like unpredictable tasks or communication breakdowns. And a communication assessment focused on her understanding of directions, so expressive vocabulary and ability to stay on topic. And finally, behavioral observations during the therapy tracked how often she made off-topic comments so we could measure her progress over time. And from these results, we developed short-term and long-term goals. So the short-term goals were focused on increasing her participation in structured sessions using visual schedules, following predictable task sequences, reducing off-topic comments, and responding appropriately to directions with support.
Our long-term goals, we have improved behavioral self-regulation, generalized use of structured routines and with visual supports to the classroom and home environments, and we have an increase in ability to use language to request, respond, and express frustration appropriately. And for the implementation approaches, we have an individual and small group therapy session with collaboration from SLP, teacher, and classroom aides to promote generalization across environments. The sessions will be 2 to 3 days a week, 30 minutes each, with classroom check-ins. Our structure follows a highly predictable sequence. It includes a greeting, review of the visual schedule, a warm-up activity that's structured, and then we're going to target communication and behavior regulation activities, as well as cooling down and reflecting on our session.
So the outcomes following Josie being in speech language treatment were a reduction of dangerous behaviors. Josie never demonstrated severe physical acting out that was observed in the classroom. She increased focus. The intervention was associated with a decrease in the frequency of preservative and off-task comments. So she stopped asking or saying, I want to play, or what we doing now, trying to get off task. There was a reduction in the number of times she needed redirection to stay focused. She showed effectiveness was confirmed when Josie improved her behaviors and it was not likely due to natural spontaneous recovery, as her behaviors had not improved in the 5 months prior to intervention. Resiliency was demonstrated when the picture-based schedule was briefly withdrawn during 2 sessions. Josie did not show a marked increase in off-task comments. And the asking for help moments on one occasion when Josie was showing extreme frustration in class, she asked to go to the speech room. This suggests that she recognized the structured treatment setting was a safe and helpful environment for her.
So kids like Josie with TBI line up with everything that we've been studying in class, because TBI messes with speech, language, thinking, and even eating. The report says kids can struggle with attention, memory, and talking for years. Every kid is different, so we have to make plans individualized for them. For checking kids out, they want real tests plus everyday checks in hospitals, schools, or wherever. And if we catch it early, we have to keep watching and get the whole team involved for talking and swallowing. For helping the kids, doing therapy at school and home includes families respecting their culture and sticking with these kids for the long haul, whether it's throughout middle school, high school, or all of it. And these align with ASHA's rules because we have to know TBI, use good tests and fixes with other pros. We get practice in hospitals and schools and have to be fair to every family. So the medical staff, teachers, parents, and SLPs have to work together, especially when kids switch from hospital back to class. And these are our references.